Well, thank you for inviting me. Thank you for your kind words, and thank you for including me with your prestigious gathering there. I've been watching the last few presentation, and it is very astonishing. Many stuff I have learned already today from your meeting. Yes, as you heard, I am Nabil El Mahdawi. I am a consultant, clinical oncologist. I work in Hull University Teaching Hospital and predominantly in the Queen's Center of Oncology. In our center, I was 10 years ago the developer of the SABR technology. And we're very proud to say we have been traveling, treating over 200 cases a year now, which is, as I said, SABR is, if you say in Arabic, means sabr, which means patient. And then in English language, SABR stands for state, action, belief, and reason, which the user in legal system, when they've been asked a question on the witness, they always ask them to use a SABR technique, which means state your answer clearly with evidence. And funny enough, that's what we also do when we deliver high-dose radiotherapy. Now, I've been given the task to talk about SABR expanding beyond the boundaries of a standard radiotherapy. But in definition, we need to understand SABR is a highly precise, high-dose radiation over a few fractions. And the conventional use, which we have been, I think has been spoken earlier today, is for peripheral lung primaries, but also for small metastases. And now we're expanding beyond traditional setting. And I've been asked over the next 15 minutes to talk about what are the areas of interest beyond the traditional use. Now, if we look at the time schema, you all know that, yeah, SABR, how is it developed? Developed over the years chronologically from 1995 to where we are now. That started with the first experience publication, on the Japanese people in 1998. Following that, the Indianas and the Stanford, they have made their publication, and they all show it positively. But we only know SABR using the way we develop it now with IMRT technology and using VMAT technology is after the RTOG 236, which is published now, very available in the Terman et al. At the JAMA, and showing the free fractions radiotherapy is possible for inoperable early stage peripheral tumor. And that has led the controversy. We can only give it for inoperable tumors. So surgery stands first, although this might change soon. In 2015, there's more the STARS Russell and the RTOG, which compared four fractions to single fractions, which I'll allude to it later. And now we're looking at beyond central lesions, which we're looking around the ultracentral zones, and we looking at the role of combination immunotherapy and how we treat also central tumors. So we are evolving in delivering the stereotactic ablative radiotherapy. Now, the first point of controversy I've been asked to talk about is what we call central and ultracentral tumors. Now, if many people talk about it differently, some people say, what is central? What is ultracentral? In my opinion, I think the best definition, you find it from the ISLAC and the Nordic HILAS, which is really recommended definition of the central lesion is more cautious, including all lesion within 2 centimeters of the proximal tree, mediastinum, pericardial pleura, and brachial plexus. Yeah, so this is called the extended, because the first definition of central, it used to be 2 centimeters from any cartilaginous airway. But ISLAC said central lesion also including lesion near to the pericardial pleura and also brachial plexus. Or the ultracentral zones, which is a GTV. Remember, this is a GTV phase, not a collective, not 4-dimensional GTV, not the ITV. It is the GTV within less than 1 centimeter of the proximal truncal tree that can be overlapping with the trachea or the main bronchi. And I'd all advise you to go into the Nordic HILAS trial, which is really have shown very well the definition of the central and the ultracentral zone. Now, if you simplify it, and you look at it, how is there, as we learned it when we were junior oncologists, which really the 2 centimeters, you put that bronchial tree and you pretty much draw a dotted line. And the reason we're worried about that, people say, why are we worried? Because there's a higher risk of severe toxicity. What are severe toxicity is a bronchial stenosis and hemorrhage. I think in the whole internet, there's only one case or two cases who had actually developed bronchial stenosis hemorrhage that has been published. There may have been cases done in some centers, they've not published it, but the one that been published and shown by treating central or ultra-centrally developed, there are, fewer than 500 cases. Now, what the advances which came from the RTOG 0813, which showed hyperfractionations, E using 60 gray in 8 fraction, is safe dose to escalate that protocol. Now, the RTOG is a really good data, and I'm not a kind of person who actually put in his presentation the detailed information about the trials, because that's actually is a domain that we all have be accessible. And my field is better just to share my point of view with you and my experience, how to apply this in my practical practice. So the doses said like the 60 in 5 is a good local control with acceptable toxicity and defines safer treatment parameter at a high risk. And I like this, and I use this in my daily practice. Any tumor close to the central or ultracentral zone, 60 in 5, or sometimes using 60 in 8 or 50 in 8. These are high doses. I will show them a little bit later on. But in Hull, where we use it, we have at most of the United Kingdom fractionations, which we all follow something called the SABR consortium. And the SABR consortium is managed predominantly in the central United Kingdom, which place called Sheffield. And I would recommend, if you have a consortium like this in India, that would be amazing, because the problem with SABR is still open to interpretations, and it's good not to have patients being treated randomly and differently in different centers. So if you have a consortium, can define what you all do in one area, because that's how you're going to mature your data. That's how you're going to learn best. And that's why I thank my colleague, Professor Hatton, to start in the SABR consortium, because he amalgamated us together to do the correct thing. So predominantly, there are three different type of fractions. The 54 in 3, which is the peripheral, 55 or 60 in 5 fractions to peripheral tumors, which touch in the chest wall. However, if you are coming closer to the central zone, which as defined by SLAC, which is we treat over 8 fractions, which is we come near the brachial plexus or we come near the main vessels. Now, the Chajing Stereotactic Uplift Radiotherapy trial is really talked about if we're going to treat central tumor. You get a challenges and you get a clinical insight. And I put it there in this little picture there to see. So the challenges, you are close to proximity, mediastinum and structure, increased toxicity, and fewer favorable outcomes. So actually, your control on the cancer is not as good as on the periphery. Now, if you want to do it, you got to do it in a highly conformed planning. You're going to fractionate it to reduce the dose and advise the imaging guidance. So the imaging guidance here become really important. So gated imaging techniques using 4-dimensional gating that also. And it's really empirical to have something called multidisciplinary management. In any SABR delivering hospital in the United Kingdom by the consortium, we're obliged to have a SABR NDT that we discuss the dosage and the technique has to be delivered. And really the idea we do this because we want to optimize the delivery of treatment. We're going to adjust the dose, we select the patient correctly, and then we can advise our technique and hopefully we can make publications. What is this 4-dimensional? And pretty much similar what you do in your own practice for standard SABR. So you have the 4-dimensional CT scan performed on all patients. We never do 3D scan. Very, very, very rarely, and that would be off protocol, which we have to do a 3D only because the patient could not tolerate the length of the 4D scan, or the patient does move cannot control the emotions, like have a tremors, or maybe the patient have very shallow breathing that we cannot achieve 4-dimensional scanning. 4D scanning should be reviewed, in patient and measure any artifact and calculate tumor motions when we do it. If a tumor motion is really rapid, is more than 1 centimeter, then we do the amplitude gating. So we amplitude the gating, we use certain phases that we can treat the tumor. And for these certain phases, that's how we deliver. 4D dimensional scanning acquired prior to patient motion, and then we do triggered CBCT performed with amplitude gated patients. So we have the 4D CT scan At the beginning, we used to do it before the fraction and end the fraction. Now we only do one for DCD, CBCT, sorry, at the end of the treatment. And if the patient is got a gated treatment, we do a triggered gated CBCT. Now, these are little publications which done by our nearby centers, which really good to learn from them. One from the Christie, excuse me, and one from the Mount Vernon Center, which the Christie have shown 214 cases from 2019 to 22. These tumors were central or ultracentral. The median dose between 60 gray, 37 to 60 gray, and they reduced to less than 44 gray in ultracentral. Ultracentral mean you are less than 1 centimeter from the main bronchi. The 217 patient received a single lesion on a multiple lesion, and 141 reported grade 1 or grade 2 toxicities, and one patient account for grade 4 bronchial obstructions. Yeah, so this is one of the cases I said. So you're really looking at about 0.5% to get bronchial obstruction if you treat it in an ultrazone, if you plan it well and you're given the correct dose. But then what's very important is your 1 or 2 year survival, it's actually 80 and 55%, and 92 to 76% on oligometastatic disease. So it was a really encouraging result to be able to challenge our fear and achieve a good survival. The Mount Vernon, they have a different techniques, and this is all data started from now 2016, where they use a SABR knife machine, and they use a 5 fractions treatments closer to the trachea, and the median dose, which was from 22 to 55 gray and ranging to 0.7 gray to 55 gray. And the 1 year survival, 82%, and they have no grade 3 toxicity reported whatsoever. So in essence, what I'm going to say, if you treat central or ultracentrals, if you follow the protocol, you do it safely, you can do it, and your risk of toxicity is much smaller than originally thought of. In Hull, we have this data, this our audit data, which we are looking at different fractionations, either the ultra hyperfractionated or the slightly reduced hyperfractionated. And we see the median overall survival, it doesn't vary between different patients. Yeah, so we have what it varies sometimes localized tumor control, but what it does not vary is a median overall survival. So all of these fractionation, I'm very, very happy for you to take a screenshot from this one, is actually is a very useful to know. Now, the next topic I've been asked by your prestigious panelists is to talk about interstitial lung disease. This is also an area of controversy. So ILD is a patient who are vulnerable to radiation pneumonitis. That's why we don't like to give them. Increased toxicity risk, that's our main challenges. We need to have strategies that with stringent patient selection, careful dosimetry, conservative dosing schedule in all forms of radiation delivered to patient ILD, and you need to have a caution possible supported by emergent studies. I'm not going to talk about this busy slide because this is the box on the left, which say ILD for us as oncologists, at least I could say myself, we just see it as a one entity. But my colleague pulmonologists, they actually see ILD as a multiple separate type of disease, whether it is one lesion, multiple lesion, diffuse, central, and peripheral. And what they say is like, most important thing about ILD is the rate of progression. How is it rapidly progression? But from the radiotherapy point of view, is the rate of clinical significant toxicity following SABR is low, and is growing evidence patient with underlying fibrosis baseline and increased risk. And that's published by CHEB. And also associated, but is still associated with grade 3 radiation pneumonitis in 32% of patients. And in 5 patients, they may develop grade 5 pneumonitis. And we know grade 4 and grade 5, the really high mortality of those cases. The incidence was grade 3 or grade 3 pneumonitis was significantly higher in patients with ILD. The overall survival, it was inferior in a patient with ILD on 3 years, 58 versus 70% on patients do not have ILD. And the patient with underlying ILD, they recommend must be appropriate counseling regarding potential risk and include fulminant pneumonitis, which may be fatal. So ILD is not a playing field. I had one patient of mine who died from ILD, which was a patient we thought is a peripheral, small and static, good health, good performance. 3 months later, after SABR, she admitted to fulminant pneumonitis, and unfortunately, she has passed away. That was years ago. And that I learned ILD is not a playing game. But if you, again, look at the Japanese, Yamaguchi has put a really good summary data, and I put that this is a really good one, which showed he had a multi-center retrospective survey. So he called all his colleagues who's doing treated ILD, and a patient who had SABR. Unfortunately, they just showed a high rate of severe pneumonitis, and 15% may develop fatal pneumonitis. And the high risk criteria, this is what really has shown us to learn from it, is honeycombing on the lung, poor pulmonary function, and if it's high V20. So if you've got patients have this criteria, avoid, do not treat them with SABR. Despite highly targeted SABR caused significant lung toxicity, and he said extreme caution when offer radiotherapy. If you have alternative therapies, which I'm really pleased to see my previous colleagues from interventional radiology, interventional pulmonology, which is targeted radiofrequency ablation. I think this is something we are exploring. Patient who can we deliver targeted ablation onto small lesion, that's something we look at. Multidisciplinary evaluation is also very important, and we need to counsel the patient correctly regarding toxicity. Now, if you want to treat patient with ILD, I suggest you take a screenshot of this screen, because this tells you how you need to take a really informed consent. And in your informed consent, you need to tell the patient a risk of mortality. My patient died, and what saves me from going to court, because in her consent, it was written there is a 20% risk of you might die from the treatment, and she agreed to do it, and she asked me to do the treatment, and that is on her choice. Clinical history examination, you need to do PET scan, CT spirometry. You need to work closely with your ILD respiratory team, because they will need to work with you about the ILD gap. The ILD gap, which just tells you how fast this is progressing. And we see from the table onto the other side of the screen, if the bigger the gap, the less likely you're going to have the patient to die from radiotherapy. Remember, the higher toxicities there is where we talked earlier that can give you a risk of death. Now we talk about detailed risk benefit. We appoint the patient, and you need to see, with the patient going to die from the pulmonary fibrosis prior to this small tumor, or they're going to die from the small tumor prior to the pulmonary fibrosis. But if I would summarize it, after you've done that, you've done the token, you've measured the gap analysis, you need to look at your V20, ideally should be less than 10% or less than 6.5%. Yeah, so really small V20. Lung dose should be less than 4.5 gray, and 1.5 liter of lung volume is less than 12.5 gray. So this parameter now in my ILD patient is actually tattooed in our radiotherapy department. Now I'm going to be talking next about the oligometastatic disease. So the definition, it's the presence of less than 5 metastases, and the objective for the local control to prolong survival. The best trial which looked around the oligometastatic disease is the SABR comment, which has survival benefit. The common size, normally lung, liver, and bone. The SABR comment is really slowly, I'm going to be just mentioning it. It looks into the overall survival of patients who have been delivered SABR oligometastatic, and look at the progression-free survival. And they have a very simple schema, which is 1 to 2 analysis, standard of care versus SABR, and they show significant deviation of the arms between treated groups and the control groups, with improvement of the overall survival. However, at SABR 41, the confident interval at 20 has not been reached. Okay. If you treat SABR oligomets, oligoprogression, this is another group. So oligoprogression, oligomet, they're different groups. When you want to treat the oligoprogression, you need to look at this picture there. You need to be able to use SABR, so a patient can do it. It's not like too unwell for it. You need to make a short treatment, because you need to sandwich it sometimes between systemic therapy. When you deliver it, you need to give the SABR first or between the treatment. You never, ever combine it with chemotherapy or systemic therapy, because this is still work in progress. We do not have enough evidence to support that. You need to look at organ at risk. You prioritize, so in a way, as if we're doing reverse planning, organ at risk has to be prioritized on the dosing, and caution when if any contraindicated radiotherapy. You need to choose a good performance patient, low dose burden. So it's not a patient who's got riddled with metastatic disease. I was surprised to see some country in the Middle East for the cert, I may call it commercial need. They are treating oligomets when a patient is absolutely riddled with disease on untreatable areas. Previous response to systemic therapy. If the patient does show good response to systemic therapy, this is a patient who may improve the quality of life or survival by treating oligo progression. So you really need to treat the progressed lesion. You need to delay the need of treatment requirement, and you maintain the control, and that is your patient qualified. Because remember, when you treat oligoprogression, you're not curing the patient with SABR. So takeaways is really just look at your patient, look, can they carry on systemic therapy? Can they be just controlled, or can we just be SABR? So it showed in all, the data which people have been collecting is effective, and they delay the need of another chemotherapy, which improve time to progression and sometimes improve overall survival. It's the strongest evidence come from non-small cell lung cancer, but we know now for melanoma and renal cell, also there is supportive evidence. Most evidence, unfortunately, at the moment is retrospective. The prospective trial is only like Gomez, which have high quality support, and this is the one I recommend all to refer to. And a SABR is a favor because it's non-invasive, highly precise, and that's different than doing metastatectomies for patients who have, oligo progression. Now, the last part of my topic today, and I hope I'm running on time, and I hope I'm not running too fast because I don't have any timing to show me how am I going within my schedule. It's the areas which has been trialed. And look at this picture. I'm happy for you to take a snap picture of this one, which tells you the area which has been shown. Single fraction can be helpful. So the brain and the peripheral lung, you get a dose between 20 to 34 to the lungs. You already have a high supporting evidence. When you come to the spine, kidney, and liver mets, you're looking about moderate or maybe insufficient evidence to support it. So if you want to do single mets, always refer to the centers who has done it. In my center in Hull, we don't do it standardly because our population is small. So if we think a single fraction or within treated field SABR required, we contact to our nearest biggest center is the Leeds, and we don't have any problem to share our patient with them, because that's how we're gonna get the patient treated correctly, but also that's how we're gonna mature our experience and knowledge. But the benefit, we need to look into the convenience, and sometimes if you work in a private setting, it can be cost effective for patient, and in NHS, any cut in treatment time, it saves NHS treatment, and it's a rapid treatment, so it's quite convenient for metastatic patient. You look at the RTO 015, it actually has a good result, which shows comparable outcome in treating patient multi-fractionally. So remember, this is predominantly is high dose palliative treatment that it may delay the symptoms, that may delay patient retreatment, and improve patient quality of life. These are other evidence of single fraction SABR radiotherapy. So you got the RTOG I just alluded to. You got the spine metastasis data, which from Anderson Schengel, and you got the liver metastasis data from Martez Mandel. And these are the different doses has been used, which they have I just shared with you the key result. As I said earlier, apologies, I don't dwell onto the depth of the paper. I just give you the message that I learned from them. And you have the access to read the detail. But I think all of them, they show that is safe and effective, local control, and good for small well-tolerated tumor. If you read those data correctly, they are not aimed to cure the patient. So why I'm saying that, there's no Frankenstein medicine. Don't get a patient who has multiple diseases and have single here and there. This is something we can give a high dose palliative that improve patient quality of life and may delay the need of next systemic therapy. So what is common to challenges, which taking me to the end of my trial? If you're thinking about treating this gray areas or the challenged area, managing toxicity is really important when we're treating them. Refining patient selection is absolutely important. What we're looking for now, we know immunotherapy has been transformational in the lung cancer management. I was very lucky to be in Japan when it was introduced. And actually, if you were there on that conference, it's like you would have seen people queuing up to this roundabout just to see the outcome. And it was amazing. And it was thrown out in a screen on the street. And we were hoping we can, add SABR to immunotherapy, because also SABR has been revolutionized in the lung cancer. But this is a work in progress. Personalized radiotherapy dosing, they're extremely important when we start thinking about SABR. So conclusion, SABR is an extended beyond conventional indications, is offering a promising outcome with careful application, and future research is must be, and all work about the dose distribution, the safety, and the improvement of the radiation quality. And that takes me toward my end of my presentation. I hope I reached the knowledge that you require me to share with you, and I hope to hear from you in the future. I will hang on for a little bit if you have any questions, but if you don't want me, I will probably just go off, because we are in London having a family holiday. Thank you.
Thank you, Dr. Nal, for a very precise and informative presentation. And because of paucity of time, I may invite only one question.
I have one question.
Okay. Thank you, sir, for the excellent presentation. So my question is, in a case of oligometastatic or oligoprogressive disease, when it is done after systemic therapy, so especially when oligometastatic disease, the dose is delivering after the systemic therapy, the tumor has shrunk from its original position. So do you use a CTV for taking into account of the primary lesion size?
If you treat a patient with oligometastasis and you chose to treat them first, in my practice, if the patient oligometastatic and doesn't, I will give them SABR before systemic therapy. Well, what you're saying there, you have oligometastasis and you chose, if I understood you correctly, you chose to downstage it with chemotherapy, and then you have a residual volume disease that you want to eradicate that with radiotherapy. This is different strategy to what I do. I think when it comes to that, it doesn't really make a big difference whether you use the original CTV or the residual CTV, because you got what limits you here is the V20 and how much you're going to be delivered. Remember, most of your patients from the data, about almost 50% of patients with oligometastatic oligoprogression specifically, they will come back in the near future for more other lesions. So limiting the volume, limiting the doses is absolutely important. Remember, as much as you would like to downstage it and cure the patient, we're looking at progression-free survival with a benefit in overall survival and in need of systemic therapy. So I would say with these patients, caution is always very useful. You try to minimize the radiation dose and keep the expectations good. I do not have any data to tell you you should treat the pre-chemotherapy GTV or post-chemotherapy GTV or CTV. This is something I think is in your own clinical assessment, but what it limits you is the volume of treatment and what is the objective you're going to reach by either extending to microscopic disease, which normally we don't do for SABR, or you want to treat just to the existing radiologically visible disease.
Thank you. And you are treating alternative day SBRT or daily treatment for SBR?
Yeah, for SABR, we treat alternate days. Alternate days, either we treat in a standard conventional stereotactic radiotherapy, or if we do it for oligomets or oligoprogression.
Thank you.
Thank you.
Thank you very much once again. We enjoyed the lecture. Thank you.
Thank you. Amazing. Thank you for letting me know. And if you